you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
You know, got his wrist pain by doing over-aggressive high fives to his buddies.
Hello and welcome to the Emergency Ultrasound Podcast. My name's Mike Mallon. I'm here again with Matt Dawson. Today we're going to do things a little bit different. We're going to do an interview. We're going to interview Dr. Vicki Noble. Dr. Noble is currently the chair of the Emergency Ultrasound section of the American College of Emergency Physicians. She also spends her free time as the ultrasound director for Mass General Hospital, which is one of the main hospitals for the Harvard Medical School. Vicki did her training at Harvard and then went on to do an emergency ultrasound fellowship at St. Luke's Hospital. So Vicki, thanks for being with us. To get started today, I'd like to ask you how you got first interested in ultrasound. What was it that really drew you to this particular area of emergency medicine?
Emergency ultrasound is one of those things that's perfectly suited to the personality types of people who like emergency medicine, because it gives you so much autonomy and so much independence in working up your patient and gives you a whole new extra tool that you can use to make your diagnoses and your dispositions. And so I think that's really appealing, is what's kind of kept me in the field. I think what started me in the field was that, you know, I spent some time overseas and I did some international work early on when I was a doctor. And it was always very frustrating in that you had very, very limited resources. And sometimes you just needed one more extra piece of information. And I felt like emergency ultrasound really gives you that little extra boost in terms of your diagnostic capability as a doctor to help make really important decisions for patients. So I think those were the two things that kind of initially attracted me to it. I have to say, there's the greatest people in emergency medicine, I think, work in emergency ultrasound, and it's just been so fun and, you know, such a vibrant community. So I think it's hard to leave it or, you know, to not get stuck once you start.
Yeah, that's a great point. I really like how you're talking about limited resources. You talked about international settings, but recently I've been working in some rural emergency departments, and even in those departments at night, it's just amazing. It's night and day what you can do when you have a machine and you don't have a machine, when you have the patient coming in with abdominal pain or undifferentiated hypotension. So that's a great point. That's one thing that I love about ultrasound as well.
And one thing I think, you know, we always talk about, you know, there's a lot of interest now in emergency medicine and international medicine, but I have to say, like, you know, to me, the people the reason why I push so hard for emergency ultrasound training for our residents is that, you know, it's exactly the settings you're talking about within this country, in the United States. You know, it's not, you don't have to go very far before you don't have a 24-hour radiologist, you don't have an ultrasound tech, and you really have very limited diagnostic imaging capabilities in this country. And so I think providing that training and providing that skill set to people is just really what we should be doing.
So, Vicki, one of the things we're interested in on this particular podcast is we want to talk a little bit about the ACEP ultrasound section, and since you're such an integral part of it, we were wondering what's been going on over the last year in the ultrasound section. Anything new? Anything exciting?
Oh my goodness! Is there anything new? Well, there's about 17 subcommittees of the ACEP ultrasound section, so I could bore your listeners to tears by going through each one and telling them all about the different things. Some of the highlights, I think, are, one, maybe some of the listeners have seen that the ACEP website has changed its homepage, and there's been a lot of resources spent on the ACEP side in terms of upgrading their website, and ultrasound just got picked for kind of the next upgrade. So there's been a group of people within the section who are working really hard to make the web page much more user-friendly, to have a group of super users who can upload and download information so we can make the information sharing on the website a lot easier, and also to make the documents available to people. I'm sure both of you and many of the listeners have heard or seen on the listserv, the same questions are asked all the time about, can I have this document, or does anyone have this resource? And so by posting all those on the website, we hope to make that more available to people. So that's going to be really exciting. We hope to have that up and running by October. And then other things that are going on, there's been a real push, I'm sure many of the listeners have seen on the listserv, about fellowships and about whether or not to apply for ACGME specialty status for emergency ultrasound fellowships. we're just starting kind of the open debate on that, but there's, obviously pros and cons in both directions. I think the pros are that people really hope to kind of solidify the place of emergency ultrasound as a subspecialty field and to increase the awareness of the rest of the House of Medicine about what that field is and what the qualifications and standards are for that. Obviously, some people are nervous that this will limit the amount of ultrasound fellowships, so we'll see what happens with the debate, and there'll be a vote in October. So for all the listeners who are interested in this, for sure come in October so that we hear your voice and your vote. There's been a lot of effort there's a group that's developing templates for reports that will be shared on the website, standardized reports for basic ultrasound applications so that people who are starting their programs can just use these templates. The idea is also that maybe industry will adopt some of these templates, and so they'll come as part of the standard package on ultrasound machines, which would be really nice.
So sounds like there's a lot that's probably going to be going on at the meeting itself at the Scientific Assembly in October then. If we're going to be talking about the fellowships and the templates, anything else on the agenda for the Scientific Assembly in San Francisco?
Well, another committee that's been doing a lot of work that probably some people have been hearing about is the Accreditation Committee. And so one of the things that's been kind of back and forth over the last few years is whether the ACEP and the ultrasound section should push for a process where each ultrasound program in the United States would get a formal review and recognition. This is not, I have to be really clear here because I know this sometimes makes people nervous, this is not accrediting individual doctors, but it's accrediting programs to make sure that their, programs and their QA processes and their image archiving and everything are kind of up to a certain standard. And one of the reasons for doing that is because there's been a lot of pushback from third-party payers and from other reviewing bodies that without an accreditation process, the reimbursement challenges are harder because people don't know that there's a quality product being offered. So we're kind of moving forward with that. There's a group, and Pat Hunt has been incredibly helpful developing a sample website, and we have a lot of the documents and processes in place. I'm not sure we're going to be debating it much at this Scientific Assembly, but over the next year we're going to be reaching out to section members to try the website and see what they think about the process, and then see about pushing that forward in the next year. So that's another really active subcommittee that will report back to the group. But the main thing, actually, I should say, because I just put this on the listserv, but the main thing we're going to try to do, I know many of the people who are listening have been to these marathon ultrasound section meetings where we have 200 or 300 people crammed into a room for 150, and all 17 subcommittees are reporting. And we're hoping this year to get the same information across, but maybe to limit the subcommittee reports just to those that have active issues and update everybody by email on some of the other subcommittees. And then we have requested space so that we can break into smaller groups so that we can have more interaction between the members and more active debate about some of the issues going on in the section. So we'll see how that works. It's going to be an experiment, and hopefully it will make it more easy for people to participate in the section business.
Yeah, I think Matt and I are both really excited to make it to the Scientific Assembly. It sounds like there's going to be a lot of interesting stuff going on, and a lot of new and exciting ways for ultrasound to expand within emergency medicine.
I hope so. Yeah, and plus San Francisco is awesome anyway.
So could you care to expand just a little bit on talking about the accreditation, how exactly that would work? Is that something that's going to be available for individual physicians working in a hospital somewhere where they may not have much of a program where they could submit documentation to ACEP showing that they've met what ACEP's recommendations are, and then they get a kind of a stamp of approval from ACEP that they can take to their hospital? So
it's really important that people understand this is not an individual doctor sort of training program. What this is looking at each hospital and saying, is their ultrasound program as a whole providing a quality product according to ACEP standards or, kind of specialty standards. So we don't have a way yet from the ACEP side to train and sign off on the training for individual doctors, and that's been something that the community group has been working on. We have developed a list of places that are willing to review individual physician scans and do some more kind of intensive mini fellowships, so people can come and work with a group that has an ultrasound program and get that kind of formal ACEP letter that says that they are trained up to a certain standard. But the accreditation program is really for hospital practices to say that this hospital has met the standards from the specialty and is practicing emergency ultrasound according to those standards. So it's not an individual doctor program as much as it is a hospital program.
So there really would have to be someone at each hospital kind of pushing this through and kind of taking the lead for the whole group.
And the idea is with kind of moving forward, the vision, I think, of the section and the section leaders of the past few years is that most programs and most hospital emergency departments, as we move ahead, should have a ultrasound point person. Because by having an ultrasound point person, we can ensure that there's a quality assurance process, that there's image archiving processes. And again, that ultrasound point person doesn't have to be fellowship trained, doesn't have to have, anything extra except maybe some administrative and management experience, which they can get through some of the management courses. Obviously, fellowship training helps and would be best, but I think that specialty feels that having someone at each site where an ultrasound program is fully operational kind of helps to improve the quality of the product. Again, that's a little controversial, and I know there are some places where there's just a few people at a site, and so obviously then the process is a little bit different. But we're trying as best we can, and we hope we've succeeded in making this a very easy online, getting documents that are templates from ACEP, and then using those to establish a program so that people have some guidance in how to set up an ultrasound program, especially in some of these smaller places where they may be doing this sort of on their own.
Yeah, that sounds awesome. I can't wait to see how all that works out and whether the accreditation really comes to fruition or not. I think if it does, I think it's going to be awesome and a great way to ensure that everybody's getting quality ultrasound care wherever they show up. Well, that all sounds great, Vicki. So one thing we like to do on the podcast is we like to ask everyone that we have on that we interview what their newest and most interesting use of ultrasound is in the department, and we're hoping that by doing this we get some more great ideas of things to expand on in ultrasound. So, Vicki, what's yours? What's your new, interesting, exciting way to use ultrasound in the ED?
I'm sure many of your listeners know that we're Mass General. We're kind of a lung ultrasound group, but I have to say, and my colleague Andrew Latepo is probably going to kill me because I'm not going to talk about lung ultrasound actually. But we've had some really cool cases in the last few weeks and months looking at the abdomen and looking for hernias and signs of incarcerated hernias and obstruction. And so, for example, we had this patient come in the other day who had a known hernia but was there with abdominal pain, was rather large, and so it was a little hard to tell exactly if it was incarcerated. And we took the ultrasound, and instantly you could see the peritoneal defect, you could see edema lining the bowel as it was kind of coming through the defect, and you could see the contents of the bowel kind of swishing back and forth within that defect. And even if you don't know ultrasound, you could kind of look at it and intuitively say, oh, hey, look, the contents aren't moving through there, and the bowel wall is thick, and it looks kind of angry and unhappy. And even our surgical consult who came down was like, ooh, that's pretty cool. So I was pretty impressed. We haven't done a lot of that, but it was really helpful and effective. Of course, we got the CT anyway because the surgeons wanted it, but hopefully over time we will convince them that this is something that they could use without getting a CT. Patients have a really hard, if you have an incarcerated hernia, it's very difficult sometimes to get the contrast in and do the CT and wait for the time it takes to get the CT. So that was pretty cool.
That's awesome. Yeah, I think I've seen, I guess, a couple of cases of that, and you're right. It really is impressive how well you can see the bowel. You can see if there's any edema, if there's any peristalsis. I think I've even put some color flow on it in the past to try to see if I can see any blood flow within the bowel wall. Looking for strangulation. It's really pretty interesting stuff. I haven't seen any literature about it. Have you seen anything out there on bedside ultrasound in incarcerated hernias?
Yeah, there's a couple. We looked at, after this case, we kind of looked into it a little bit, and there are some case series, and there's some, kind of like 20, 30 patient case reports of describing the characteristics. And, most of it's done by non-emergency physicians. So there are a few GI doctors who use it. And then in Germany, there's a couple reports that were pretty impressive. But I haven't seen people like do a trial comparing, diagnostic accuracy compared to CT or things like that. So that's a great research idea for anybody out there who's listening.
idea for the listeners looking to get into some academics. All right. Good stuff. Well, Matt, do you have anything else for Dr. Noble today?
No, thank you so much for coming on and telling us about what to expect with ACEP.
Yeah, thanks. This has been great, and hopefully we can do more of these interviews with the leaders of emergency medicine ultrasound in the future. Dr. Noble, thank you for coming and taking a couple steps down the ladder to be interviewed by Matt and myself.
Actually, this is a huge step up the ladder because although I guess next time we'll try to get the video to work.
Yeah, next time we'll work on the video and we'll see if we can't get Dawson a facelift before we do that. I think
working on it.
It'll all be great.
Hi everyone, you just listened to an interview of Vicki Noble, and you may have heard her mention something about ultrasound for hernia. You may or may not ever have heard of that before, and I've heard of it but not really done it. So anytime I hear someone 10 times smarter than me mention a cool new application for ultrasound, I want to look it up and learn about it. So we looked it up, and we're going to just spend 5 or 10 minutes telling you a little bit about ultrasound for hernia and if it's actually useful and how to do it.
So really, you can use ultrasound to try to diagnose hernias, you can use it to try to reduce hernias, and you can actually use it, we think, well, we don't really know for sure, you might be able to use it to see if a hernia is strangulated or not. And I've actually done this like twice, I think, in the emergency department, Matt, so I haven't done it a lot, but I think I'm going to start doing it more often because this data that we've been looking up and the information that we found is pretty interesting. So let's get straight to it. So can ultrasound really diagnose a hernia? And here's a study that was published in 2011, actually, so pretty recent, and this is 297 patients, and they basically presented to an outpatient surgical clinic where they had pain that was consistent with an inguinal hernia but had sort of a normal or an equivocal physical exam. And what they did is they basically decided, based on exam and based on history, whether they thought these patients had a hernia or not. And then they sent them off for blinded ultrasound. And this isn't ultrasound performed by ED docs. This is ultrasound performed, by a radiology suite. And they found a sensitivity of ultrasound was 94% for diagnosing inguinal hernias, and they're basing that against surgery. So all of those patients that ended up having an exam and a history consistent with hernia went off for surgery anyway, and 94% is not too bad.
No, that's pretty good.
That's pretty awesome. So that's 297 patients, and that's a pretty recent study, actually. Here's another one looking at 120 patients, and this one's maybe even a little bit more impressive. So these 120 patients, they basically had an exam and a history consistent with an inguinal hernia, and they were sent off for blinded ultrasound, also at the radiology suite. And interestingly enough, the surgeons thought that all 120 patients had a hernia. Turns out only 118 did, and ultrasound was more accurate than the surgeons at diagnosing that. So 100% sensitivity and 100% specificity. So the two that ended up having a hernia on ultrasound also had normal surgeries because they went over to have surgery anyway. So that's pretty interesting also. One thing you can do is you can use the ultrasound to try to diagnose whether the hernia is strangulated or not. And we don't have a lot of data on this, so we don't really know whether we can truly do it or not. There have been a couple of case reports. One was published on the Internet Journal of Emergency Medicine, and the other was published by Dr. Blavis in 2002. And both of these, they used peristalsis, bowel wall edema, and pulsed wave or color flow Doppler to try to decide whether the bowel wall is losing blood flow or not.
So in all these slides you've got poop sac, but you've yet to say that.
I was waiting for you to say it.
Okay.
That way I can blame you.
Now the ice has been broken. Now we can call it what it is.
It's a poop sack. So this is an interesting study that I think Matt wanted to tell you about.
Well, this is a study. I'm a little more interested in this than the others. The other ones, they were all going to surgery anyway, so okay, whatever. It didn't really change much, didn't really do much for me. This one is pretty cool in that this is a study of patients, 112 patients, who they came in with incarcerated hernias. These are patients like we see in the emergency department. And these patients, we push on it, and if we can't get it to go in, we send them to surgery. And it would be great if we could decrease the emergency surgery rate. It would be better to schedule those at a later time. That's going to decrease morbidity, hopefully. And what they were looking at, they said, well, what if we used ultrasound guidance to actually try to reduce these. And how they did this is they put the ultrasound probe on. They had two different sets of patients. They divided these up. They had about 60 patients who they just did a normal 2 tries at it, and if they couldn't get it in, they sent them to surgery. The other group, they gave it 2 tries. They couldn't get it in. Then they put the ultrasound probe on, and they looked to see where the defect was, and then tried to push specifically back into that defect. And this is pretty cool. It reduced the emergency surgery rate from 10% to 2%, which is a pretty big difference. It saved like 4 patients in the ultrasound group from going to emergency surgery.
Okay, so wait, there were 2 groups. One group they just pushed, and one group they pushed and then did ultrasound?
Right.
Okay.
So it may have been maybe a better study design to give it a 3rd try in the manual group too. So maybe you think, well, just those last ones went in just because they're pushing a 3rd time. So if you're like that, if you want to say that, then why don't you repeat this study and quit being a baby and just do it. But I think this is pretty cool. I think this actually made a difference. Is that what you're getting at, Mike?
No, that's not what I was getting at all. I was just trying to clarify because you were confusing me with all that speed talking.
Okay, sorry.
All that Kentucky speed talking.
I apologize.
So 8% decrease in emergency rate of surgery. That's pretty awesome.
Yeah, a small study, but that seemed like a pretty nice
It gives me hope.
Decrease.
And I like hope.
It's worth trying at least. I mean, this is a picture from that actual study. We stole it from the study and put it in here. You can see the fascial defect, and that's what they tried to push the bowel loop back through once they identified it. So, I mean, this is something that you could at least try in the emergency department, and they had pretty good success with it.
We didn't actually steal this from the study. We have borrowed it from the Scandinavian Journal of Gastroenterology in 2005, June edition.
Steal?
No.
Sorry.
I don't think he said steal. I think he said borrow. And it's not actually the same picture. It just looks very similar to that picture.
Just with the same labels.
Okay, so here's a case for you. So we didn't want to talk about all this ultrasounding of hernias without giving you some ultrasounds. So here's a case. This is a patient that I saw a couple years ago. One of the few cases that I've actually used ultrasound in the diagnosis of hernia. And they came in with a physical exam looking very similar to this, where they had sort of a bulge over the inguinal region, and it had been sticking out for a long time, and they had a good deal of pain there and some abdominal pain to go along with it. So I was concerned about the possibility not only of hernia, but of strangulation. So here's an ultrasound image of that particular hernia, and all I did was take the linear probe and just placed it right over the bulge. It's sort of hard to miss. In this particular case, it was at least. And here you see basically a defect in the fascial wall and some bowel sticking out of a direct inguinal hernia. So this is bowel wall and some schmutz inside the bowel wall. And although I'm moving on this image, if you would sit still with the probe, you would notice that there wasn't any peristalsis. Here's just another image sort of moving down the bowel wall, taking a look at the area. And you can see there's also some edema surrounding the bowel wall, concerning for a little bit of fluid collection around the bowel wall. So no peristalsis, edema. The bowel wall to me looked a little bit thickened, but I don't really have any frame of reference, so I'm not sure if that's actually true or not. And then here I put the color on the bowel wall and didn't see any color flow in multiple different areas of the bowel wall. So basically I called the surgeons and I was like, hey, you can push this in if you want. I'm not pushing it in. I think you should probably take it to the OR. And I showed him these pictures. He happened to be a pretty good guy and took my word for it, took him to the OR, and ended up taking out a little piece of bowel.
What did he tell you, that the bowel was dead after surgery?
Well, it looked grayish, like whatever, that term they use. I don't remember the term.
Grayish.
Yeah, grayish.
That's it.
Yeah, I don't think that's the term they use.
No, it's his.
Okay, good. It looked grayish. So that's it. So that's my case. I don't know. I don't have much else to offer here. Just a quick little blurb on hernias.
Yeah, we would have included a lot more pictures and examples, but it turns out a lot of the pelvic pictures aren't exactly suitable. But there are hundreds of pictures if you just Google image Mike Mallon inguinal area. There's apparently a lot on the internet, so just look that up, and you'll see some great examples.
Awesome. Thanks, Matt, and thanks, everybody.
Hey, everybody, welcome back to the Emergency Ultrasound Podcast. I just want to say it before you did. You gonna start over?
Yeah, start over. You do it.
All right. I thought you were trying to do it, so I was trying to beat you to it.
Yeah.
Everybody, wait, what are we doing? This is on the Vicki one. All right, ready? We'll start again. All right, so we just heard an interview. Wait, who was it? Vicki. All right, so you just listened to an interview of Vicki Noble, and you may have picked up on her.
Enunciate.
Hi everyone. You just listened to an interview by Vicki Noble. If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.